we're talking about comprehensive management of obesity today, and I want to thank Dr. Bauer and Dr. Kilpatrick for organizing the debate event. Apart from SARS, I know heavy in the disclosures. But today we're going to talk about the epidemiology and problem of obesity and the diseases associated with it and its pathophysiology. There's like on management of obesity and how lifestyle, nutrition, and activity can help weight loss, and what are the different medicines and future medicines, and then how bariatric surgery can help us basically. So WHO defines obesity as an abnormal or excessive fat accumulation because excess fat causes a risk to health. And we classify it based on BMI. So as you know, BMI less than 25 is normal weight, 25 to 29.9 is overweight, and about 30 is obesity. And beyond BMI 40, it is class 3 or severe obesity, where most of the diseases start. Okay. And childhood obesity is 95% of the weight. BMI is the most widely used tool to quantify weight obesity because it's easily calculated and available, weight divided by height squared, easily reproducible anywhere. Most of the EORs have it, and we can track this BMI over time, and we can do population studies with BMI. But there are some caveats with the BMI as well. Because they say Arnold Schwarzenegger is heavy for his height, so his BMI will be high, but he's muscular, he doesn't have enough fat. So he's healthy where BMI is high. Whereas older patients, 8-year-old with a BMI 26, very less muscle mass, were very affluent. Is he really healthy with BMI 26? No. So BMI doesn't review the percentage or the adiposity of and then, so the better effects are bioelectrical appearance and DEXA scan even better to tell you how much fat you actually have. Waist circumference is also good to measure along with the BMI. And BMI cutoffs are different for different populations. So especially for religions like me, like South Asian, the BMI cutoffs are different. Like in some literature, BMI about 35 was actually obesity, not BMI 30. In Hispanics, BMI about 37 is obesity, not BMI 30. So the BMI was revealed everything. Over the past 20 years, our weight, race, obesity rates have skyrocketed. In 2000, it was 30%, but now it's 42% beyond. And if we don't start this progression, we'll be beyond 50% by 2030. More staggering is the incidence of severe obesity, BMI more than 40, 9.2% compared to 4.5% 20 years ago. And this graph of obesity parallels the diabetes incidence because the factors causing obesity are also causing the diabetes. Why is weight dangerous? Because it's linked to more than 100 weight-related diseases. Most common cause of death is this heart attack, ischemic heart disease, causes hypertension, heart failure, arrhythmias, diabetes, osteoarthritis, low testosterone, infertility, fatty liver, GERD, hemophilia, unrelated disease. These are the top 10 causes of death in USA in emergency. You can see 8 of the 10 are directly related to obesity, heart disease, cancer, stroke, lung disease, diabetes, kidney disease, chronic liver disease, and COVID-19. So instead of treating each one of these piecemeal, it's important to attack the root cause, which is the basic. So mortality and obesity are related in a J-shaped curve, where there's a sweet spot of BMI 22-45, where the mortality is the least, but as we keep going up on the BMI, the mortality increases. Similarly, if your BMI goes down to less than 22, your mortality may increase. So that's the idea of BMI. Now, obesity, you see the staggering costs, like clearly in the US, costs $1.4 trillion. Because obesity leads to more and more chronic conditions, more rates of hospitalizations. You have to see more and more doctors in terms of your diseases. You have to be on more and more medications, and you lose time, work, illness, and all these leads to high expense. So obesity is costly, not for the patient, not just for the patient, but for the country as well, and for the employers too. don't know, it doesn't show up. But okay. So I don't know why it's missing. So causes of weight gain are multifactorial. So genetics is only 5 to 15%, but the number one cause of obesity in US and the world is the obesogenic environment. So the food industry has developed new ways to make the foods cheaper, tastier, more addictive, and it's easily available and very convenient. And then there are certain psychosocial factors on our part, like lack of education on nutrition or lack of income. Like you can't afford healthy food, whereas healthy foods are costlier and cheaper foods are unhealthy. And then you're eating in front of TV. You have high stress jobs. You're eating all the time, like food availability. Next is hormones, like postmenopause, high cortisol, low thyroid, high growth hormone, all these contribute to weight gain. And then there are many medicines. It's not just steroid, antipsychotics, antidepressants, antihypertensives, work control drugs, they all lead to weight gain. But all of these have common thread that they make you eat more, you're getting more nutrition, and you're getting less and less active. Those are the causes of weight gain. There's nobody chooses to gain weight, right? Because there are factors which are led to the weight gain. You need to identify that. So this is the seesaw of weight. On one side is the energy expenditure. Let's say, for example, let's say I eat 2,000 calories to maintain my weight, and they are necessary for my resting metabolic rate and my physical activity during the day. And when I'm eating, I also burn fat off when I'm eating. So the 2,000 calories, if I'm doing more because of my behaviors, because of habits, I'm getting more calories than I need, then my weight will go up. And this is what is happening day in, day out in our life. We're getting more food, but we're not burning it off as much. But then there are individual differences in genetics and behavior. This is a very busy slide, but you all have to know this. So this is an ideal situation that we wake up in the morning. We had a small shrunk cell which releases the hunger hormone. That's why we eat. So this really goes to the AGRV and MPY neurons in the brain and stimulates your appetite and causes the food crave. We're hungry, that's why we eat. When we eat enough, our large intestine releases GLP, our small intestine releases GIP, and this stimulates your RC and CAR, which suppress your hunger. Those are satiety neurons. So once you eat enough, your hunger goes down, we feel full. And then insulin, if you inject in the brain, it suppresses hunger, but peripherally, insulin, and pushes all the food in the cells, liver cell, fats, and muscle cell. It makes you gain weight, along with carbohydrates. And then as Dr. Reddy also pointed out, the more fat cells you have a compensating mechanism to control your weight and weight and hunger. Fat cells make leptin, which prevent further weight gain. But there's downregulation of leptin receptors because of stress and because of the kind of foods. We have perceptible leptin resistance, and we're not listening to all that. We're pretending to eat. So this is an ideal world, but we don't live in an ideal world. We have many non-homeostatic factors of eating, like stress, acute or chronic stress, which leads us to eating more. Prior experiences in hands, we know that ice cream tastes good, right? So we know that cereals, that sugary foods, they cause the addiction, and those are habits, it's tired, and we keep eating that. Lots of food available, we eat. If you're a shift worker, you're more hungry, you're distracted, and same with sleep deprivation. If you're not, sleeping enough, you have more packed to eat, you're distracted, you make wrong choices, you're more hungry, and that's why you gain weight. And emotions and mood, all these non-homeostatic factors lead us to eating more. That's the problem. So what is the treatment? So you have to remember these: behavioral therapy, eating, activity, medicines, and surgery, right? BEAMS. So it's a reverse pyramid because the top three are the most important. The lifestyle therapy is behavioral, eating, and activity. If you're taking medicines, not taking medicines, these are the basics that everyone has to do. Next is medicines. Medicines should are indicated when you try the lifestyle and you're not lost enough, and then medicines will suppress your hunger. It will make you do the lifestyle changes feel better. So you tried all that, but you can't afford medicines, you have side effects, or you haven't lost enough, then you opt for surgery if you still qualify. So what are the behavior drivers of eating? So food with high fructose corn syrup and low aspire fats are really tasty, cheap, and addictive. And since the 1970s, ever since the Farm Bill of 1970 was scrapped, it's a very unhealthy food environment where fats were vilified and food industry started making more and more sugary foods along with high fructose corn syrup. And food was everywhere. Still convenient, drive-thru, fast food, restaurants, groceries. Cheap foods are very unhealthy and healthy foods is costly. When we are in stressful situations, we do poor choices, we comfort foods, we have cravings, emotional eating. And in social obligations, we go to parties, we eat more, we eat the wrong kind of foods in buffets. Childhood food habits and habits, like, since childhood we're eating sweets, burgers, soda, pasta, rice, fruits, we love it. If you forget about food, the food industry will market it. They'll show you billboard ads, TV ads, YouTube ads. Food is everywhere. You cannot escape it. Plus, there's lack of information on nutrition. My patients ask me, "What? Really? Banana is just sugar? I didn't know that." So there may, misconceptions. They confuse you with the food labels and servings. So what kind of diet is the best? How will you get that? Like, what diet should I follow? There's so many diets on the market, but the best diet is the one that you can adhere to. Either diet is specific to a patient, it's sustainable, and you should be long up. Because diabetes, weight loss is not a sprint, it's a marathon. Because the body will try to make you regain weight. The goal is to suppress the hunger with the least amount of calories by eating less. So, a provider or dietitian should prescribe a reduced calorie diet to the patient, which is around 500 to 750 calories less every day than you eat. That's according to ACE diet. It should be based on person preference, and the patient should be given options, meal plans. There's no one size that fits all. Patients should like it. Meal replacement is a great way to reduce your calories. This is what I do in my clinic. Encourage them to do a low carbs, low fat, high growing, high fiber, low calorie meal replacements, and at intermittent fasting you can. But do we have time to do this for everyone? That's the challenge. Like, how you tell all these things. If you're busy and you don't have access to dietitian, you can refer them to commercial weight loss programs like Weight Watchers, Jenny Craig, VeriFast, OptiFast, Optavia. They can use that for diet control, and you can manage the lifestyle, behavior, and medications. So physical activity and exercise is really, really important. It's not just for weight loss, but it's most important for weight maintenance. Once you lose enough weight, you can't suppress your calories into more. How will you lose weight? It only ramp up your physical activity. It helps with body composition, like more muscle, less fat. It improves insulin sensitivity. It improves metabolism, HDL, cardiovascular, and mental health. So the Department of Health says you should do cardio or aerobic activity at least 150 minutes per week, so 30 minutes 5 days a week. But you also have to do muscle strengthening activity. Why? Because if you do calorie restriction and you do exercise or cardio, you lose muscle. We never want to lose muscle. We want to gain muscle first by the weight shape. So we might do the kind range, walking, incline or hiking, roll or stationary bike, elliptical or circle, rowing, pool walking, pool aerobics in patients with arthritis, whole body weight training. We can go on YouTube, or we can get a trainer, or resistance band, or just chair exercises, right? Like, the patient should be given options. So what are intensive lifestyle interventions, which are the basics, right? Lifestyle monitoring to change your behavior, dietary composition, physical activity, sleep, and stress. So they did that in 2002, diabetes prevention program. There were 3 arms, placebo, metformin, and lifestyle. If you see in 6 months, lifestyle group lost 13 to 14 pounds. As you can see over the next 4 years, those 3 arms, they met each other. So you see the lifestyle interventions, people who start doing that and the weight goes up. Similarly, when they did in 2008, it's lifestyle versus placebo, lost 20 pounds. But after 5 years, they went again. So people look to see and they regain the weight back. Why? Because if you lose weight, 10% weight reduction reduces your energy expenditure by 20%. Your body punishes you for losing weight. It makes your skeletal muscle more efficient. It causes metabolic slowing. Body thinks that you're getting sick by losing weight. It increases your hunger. These are compensating mechanisms. Try to get you back to the set point. Right? From 200 you went to 150. Body will try to get you back to par. But this set point persists for 6 months to 7 years. And so basically when you lose weight, you expect to really gain metabolic slowing and you act for it. So that's when the text is missing here for religion. So how do you choose anti-obesity medication? So number one is cost, right? So the first generation, the older generation, are cheaper than the newer ones. The newer GLPs are so costly. And next is you have to know their side effects and contraindications. And their profile, and based on that, you get the message. So if someone has pancreatitis, you will not try GLP. And next is efficacy. Obviously, we know the latest, like Dr. Bao show, that tirzepatide has the best efficacy compared to entree, which is only 5% weight loss. So, do you want a vegan injection? Do you want a daily diet? Or do you want to target your hunger or your cravings? Because all these medicines target different functions. And then you have dual benefit in covered diabetes, anxiety, or metabolism. So you choose medicine based on that. So these were the OGs, like 2013, Fentanyl or Yersinia was first approved to give you 9% placebo-suppressed weight loss. Next was Saxenda, which is not used because all the Saxenda companies now they're making semaglutide in their factories. Then next we have Contrave, which help with cravings, anxiety, depression. So these were the three older generation medicines, and lorcaserin was taken off market because of cardiovascular issues. And then in 2017, endocrinologists started prescribing Ozempic or semaglutide for diabetes, and these were the sustained trials. It gave you a good KOC reduction of 1.6%, but it also showed weight loss of 6 kilograms, which was unheard of before that. It was better than liraglutide. And then we started doing trials for patients with obesity, without diabetes, and in 2021, this landmark trial came, step 1, where it shows semaglutide 16% versus placebo 2%, and the whole obesity paradigm changed. Everyone was so excited because we never saw these results before. And then there were multiple step studies after that, select trial, NASH studies. They all show like 70 to 80% weight loss in patients with obesity. We got excited. I'm really excited about this. Oral semaglutide 50 milligrams is based on Oasis 19. You can see the weight loss is 15%, which is superior to Wegovy. So we know there are short-resistant injections. So oral addicts, we can wrap up the production and hopefully this will be approved soon. Next, so what is the mechanism of GLP? Dr. Bao already mentioned, so I'll quickly go through this. It's primarily an IBD medicine. So increases insulin secretion when you're eating and reduces glucagon. And then in the liver, it reduces the glucose production, so it controls lipase. But it goes to the brain and it increases the POMC and COT and suppresses your hunger and increases satiety. So your hunger noise is suppressed. It is like just don't think about food like I used to. Don't have the cravings anymore. And then to the vagus nerve, it goes to the stomach and slows you some down. The food stays there for longer, you eat less and you feel full, so you're not eating as much. You're eating half the calories that you used to. Plus, there are other secondary benefits in the fat cells and muscles in the gut. Next came the GLP-1 and the GIP combo, which is tirzepatide. In 2031, the CIRCA study A1C reduction of 2%, like Dr. Bob showed, but this time the weight loss was 11%. Do you remember Ozempic was 6%? This was lab. So they tried for obesity, and some on one trial in 2022, it showed 32.5%. We never saw such numbers. These are comparable to gastric sleep. So it was occurred in 2022, finally, the 2023 for obesity as well. But there in 2022, many people use Mounjaro, as you know, off-label, and saw their results. So how does this work? You already know the red side is GLP. So how does GLP work? It reduces nausea. So actually, dessert type is much more tolerated than semaglutide, and it also releases more insulin. And it actually, literally, it causes lipolysis, like fat burning. So you lose more weight to the GLP and GIP compared to GLP alone. Next is they went one step ahead. So GLP, GIP, and glucagon receptor. This is retatrutide. You see those numbers, 24% weight loss in 48 weeks. This is the best so far. These results were displayed at 88, but it's only phase 2. And I think this will be the future. So you see 25% weight loss in here. See that 25% weight loss in 50% of the patients. That's amazing. So how does this work? Just like GLP and GIP, the glucagon receptors, it works everywhere. So kids, the liver, brain, heart, every aspect, the receptor covers everything. So now we're in GLP-1 plus AR. So not just GLP, GLP plus GIP, inoxidizepatide. Next plus GCG is retatrutide. There are studies with GLP and glucagon agonists. There are older tablets. Few of them failed, but others are still in progress. We had GLP and amylin, just Cadre Sema, which gives you like 20% weight loss, so I'm pretty excited about that. Then we have GLP plus PYY and GIP and diets. So I think the future is bright. We'll have many more medicines in the future. Next is Vimagrumab. So this is a different kind of medicine where it blocks activin type 2 receptor, which prevents muscle loss. So when they compared this to placebo, they found out that patients lost 7.5 kilograms of fat mass, but they gained 1.7. But you know, in every other medicine, you lose muscle and then you lose fat. This medicine, it protects muscle, makes you gain weight. So there is hope that if you combine this with GLP, could actually keep the muscle, and you can here do sack, and you throw in some exercise and weight training. I think you'll keep the muscle and it will actually change your body composition. We're excited about this. Now, these are all FDA approved until now. These are the non-FDA agents. So these are the non-FDA agents, like the GLP-1s approved for diabetes, like Trulicity, Ozempic, and Victoza and Mounjaro. There's still GLP. We can use that for weight loss. Metformin gives you 35% weight loss according to the DBP study. Glucagon for craving suppression. As you do, like the higher your A1C, the more the weight loss, but as the A1C gets better, your weight loss goes down. Artopyruvate, the suppress hunger, along with phentermine, they have zolicine, acarbose, and stimulant. All these are non-FDA approved for weight loss. So next is bariatric surgery. So this study, the Swedish obese subject SAM, was the longest study, follow-up of more than 20 years. And they found that patients who had gastric bypass, initially they lost 25%, but over 20 years, they kept off 45%. That's significant. Right? With C, they found 25% weight loss, and then eventually the patients kept off 20% for the next 20 years. Banding was similar, but we don't do banding anymore as much. So this study shows that with bariatric surgery, you can lose weight and keep it off. So what are the different procedures? So these days, 8% of our surgeons do gastric sleeve or vertical banded gastroplasty, where they take off 70% of your stomach. So you're left with a banana-shaped small stomach where you can't eat much, you feel full early, you feel more, you feel nauseous. and it reduces renin and increases GLP. So in the first year, you lose a lot of weight, right? And after that, you start gaining it back for a meso style. 20% of the surgeons here in America, they do the gastric bypass, where there's more malabsorption, even smaller pouch, and there's propensity to more side effects. So that's why we won't use that anymore, unless they have like bad esophagus or GER, and the contraindication sleep. And the others like banding, like barely anyone does it. Everybody's just taking the Zymes out now. And then there's BBD with the diurnal switch. But the criteria is BMI above 40 without getting complications, or if you have about 35 and you have some weight to their complications, then you do opt for bariatrics, or if your BMI is about 30 and you have diabetes and other complications.
Are those stats locally here or
These,
80/20? Yeah.
yes, local, according to the ASDMS. So look, this started in 2004 by Dokwa, where they saw that 90% of your complications or diseases with obesity, so that all these mentioned on the left, 90% are data improved or resolved. So no other procedure can prolong your life or improve your mortality like they answered in the right patient. But again, not everyone wants it, not everyone likes it, and there are side effects, but this is the most efficacious. So this slide shows you the degree of weight loss, like lifestyle interventions, 5 to 10%. Then we have Paracet, then Saxenda, then Pycemia. Then you have Ozempic or semaglutide for 30 to 20%. And then you have Tirzepatide, 20 to 25%. Then you have sleep, and you have gastric bypass. So I show this slide to my patient and tell that if you want this much percentage, these are the options that we have that we can choose. They make a informed decision. So, to summarize, obesity is a very prevalent disease with varied manifestations. It's a huge burden on patients and economy. Obesity is a disease and it's not a personal choice, so it should be treated stigma-free. And it's multifactorial, a complex pathophysiology, and very treatment responses. Not everyone gets the same response. Initial treatment is always a lifestyle aimed at behavior change. Then choose a sustainable meal plan and increase the physical activity and intensity, and use appropriate first generation and second generation masses and bariatric surgery in the right patients. Thank you so much. And I have a bonus slide. This is medication use weight gain. We can view this later. But now that we have time, few minutes, I want to tell you what my favorite patient that I saw. So this patient had gastric sleeve 20 years ago, eating in all his weight to 438. He started seeing me in way to at UMS. I just put him on Phenytoin, metformin, and started walking. And then we get in the Manjaro, and then he came. Look at his weight loss. Kept going. He lost 175 pounds in 1.5 years, and he's ripped, like weight training, and he's still making his weight. Loves it. This is my star patient.
How old is
45.
Do you monitor your patient's muscle loss? Do you have a way to do that?
I want a diabetic to if it is like in what is higher, but again, costs. Right. Because it's not reimbursable that much. But I would love to. And then I can actually show it to them. Like, hey, you're losing muscle, you better exercise, eat more protein. Yeah. And then I have a proprietary bias sheet by Canvas that I show that I didn't do here. Which tells them like comprehensive knowledge of the base. I just empower them, but they are the one who has to do it.
I've definitely had some people who are older who had their GLP-1 ratcheted all the way up, and they come in and they're older, they look emaciated, they look totally sarcopenic, and I'm just wondering, like, I mean, this is another extreme. What are we doing to these people? Like, no.
So basically, some art education you have to tell with like you're doing a disservice to yourself by going below BMI 42 because you need some fat in times of sickness, like especially when you're older. So what are they aiming for? Like, is there a cosmetic side to it?
Not necessarily that they just start panic. They're starting, it's necessarily still there's a BMI still 30. So we have a chart that they're a
Is not good. So and then imagine like we are endocrinologists. Imagine what's going on in the medical spa community who are getting these tirzepatide uncontrolled. It is taking it and there's no supervision. It's scary.